So now it's my pleasure to introduce Dr. Karina Drake. She is a geriatric psychiatrist currently practicing at the University of Colorado Anschutz Medical Campus. She graduated from Albany Medical College in 2012, where then she went on to complete adult psychiatry training at the University of Michigan in 2016, followed by a geriatric psychiatry fellowship in 2017. So with that, please help me welcome Dr. Karina Drake.
Thank you. Thank you, Jody, for that introduction. Like Jody mentioned, so I'm a geriatric psychiatrist, and today I'm going to be spending some time to talk about the impact of substance use as we age. And before I get going, I do want to take a couple minutes just to talk a little bit about what geriatric psychiatry is, because in general, I think it's a less well-known field of medicine. And so, what I specialize in is basically the treatment of psychiatric disorders in older adults, so usually those over the age of 65. So that includes depression, anxiety, bipolar disorder, psychotic disorders, substance use disorders. And since that cohort of patients oftentimes has more medical comorbidities, and also there's a higher incidence of memory problems, kind of the specialty of geriatric psychiatry is treating those psychiatric symptoms in the setting of medical complexity and also cognitive difficulties. So obviously through my work, I'm very passionate about the mental health of older adults. And so, really happy to be talking about this with everyone. And if there are questions or issues afterwards or down the road, if I can be of any help, just please feel free to reach out to me and let me know. So an overview about what I'm going to be discussing today. So first, I'll just be providing some general information about what defines a substance when we think about substance dependence, and also what does dependence mean? And dependence is really the medical term that we often use to define addiction. And throughout this talk, I'll probably be using both terms interchangeably. I'll also then spend some time discussing the most commonly used substances in older adults, so primarily alcohol, and then also discussing important prescription medications that can lead to addiction. I'll also go over the impact that substances have specifically on the elderly, and how that differs from the impact of substances in younger adults. And then lastly, I'll go over some resources in terms of how to screen for substance dependence, and then what are some treatment options should substance dependence issues arise. So when we think about what a substance is, because of course that can be a very broad term that can be used for a lot of different things. But when we think about it in the terms of substance dependence, we're really talking about drugs that are mood or mind altering, and that they also, when taken, affect the brain in a way that can put an individual at risk for addiction or dependency. And I think that second part of the definition is important because as a psychiatrist, I prescribe other medications like, let's say, antidepressants or mood stabilizers that certainly can change thought process or change mood. But unlike medications that can lead to addiction, antidepressants don't affect the brain in the same way. So there's not that risk for dependency like with other drugs. When we think of substance dependence, they can be illicit or not. So, commonly legal drugs that can be used or that can lead to addiction are things like alcohol, marijuana, and then of course also there's illicit substances like cocaine, heroin, methamphetamines. When we think about substance dependence, there are certain prescription medications, so meaning that there is a very legitimate role in medical practice for their use, but at the same time, when overused, they can affect the brain in a specific way that can lead to problems with addiction. And so the most common prescription medications that we think about that carry risk of addiction are opiate pain medications and also benzodiazepines. So I'll be touching more on those medications later as well. So why are certain substances and drugs addictive? And I alluded to before that these drugs work on a specific brain pathway that can then lead to problems with dependency, and that's the rewards pathway. So when you look at this slide, on the way left, you can see a picture of the brain, and this is where the brain is kind of cut sagittally, so right in half. And there are certain structures that are highlighted in red, and those structures all are connected by different neurons or brain cells, and together they create the rewards pathway. And the rewards pathway is what's lit up whenever we do something pleasurable. So like in day-to-day life, that could be eating food or listening to music. And when that pathway is activated, there's dopamine that's released. And dopamine is a neurotransmitter, so basically just like a chemical that's circulated throughout the brain, and that produces that kind of positive feel-good effect. And so when we look at the picture in the middle, so this is an image of two brain cells, so two neurons, and what happens when, let's say, like you eat a piece of cake. So that rewards pathway is lit up. So the brain cells, there's a release of dopamine, and you can see that by the little circles between the cells. And that then causes the brain to produce that kind of positive feeling, like that, you know, this cake is good, this is a pleasurable experience. Substances that are addictive, what they do basically is they hijack this pathway and they activate it to a much, much larger degree than any kind of pleasurable, like day-to-day activity. So the picture on the far right is what it looks like between two brain cells when somebody, let's say, for example, uses cocaine. So cocaine causes a massive release of dopamine, and so it subsequently produces an intense euphoric feeling. And that's what drives repeated use, because people have this intensely pleasurable experience, and the brain looks to kind of have that experience again, and so the substance is repeatedly used. However, the brain is actually very smart and also plastic, meaning that certain behaviors or substances that we take repeatedly actually causes the way the brain functions to change. And so the brain, since it's not really used to this constant and massive release of dopamine, what it does is it dampens down the response. So the brain cells that contain the receptors that would respond to dopamine, they downregulate. So if you see the picture on the right, I know it looks like a lot of information, but basically what happens is the first picture is a normal brain where there's normal release of dopamine and there's a normal number of receptors to accept the dopamine. And so that's what happens when people aren't consistently using substances. The second picture is if somebody is repeatedly using something like, let's say, cocaine, and the brain is completely overwhelmed by this constant and intense release of dopamine. So what it does is it decreases the number of receptors. So the same amount of cocaine, while there's still that dopamine release, there's less of an effect that's seen. And this creates tolerance, where people with time need more and more of a specific substance to produce the same effect, because the brain has kind of down-regulated or tampened down the amount of response from the dopamine that's released. And this with time can also create withdrawal symptoms, because now the way that the brain has functioned has changed. And so when somebody isn't using the substance, the amount of neurotransmitters is dysregulated. And so people can experience very uncomfortable withdrawal symptoms that also drives the desire to use. So these brain changes that we see are responsible for the symptoms when we talk about dependence or addiction. So the warning signs of addiction first are that people develop cravings. So they have a constant or intense desire to use, which is driven by that desire to have that euphoric, feel-good effect. At the same time, with repeated use, the brain decreases its response to dopamine in the substance. So there's tolerance. So people are needing to use more and more to have the same or similar effect. And also, we see withdrawal symptoms. So because of those brain changes, when people aren't using, they experience very real psychological and physiologic changes that also trigger the desire to use. And because of this cycle, we often see erratic behavior. So when people are in the withdrawal phase or craving, they can often go to extreme lengths to get the substance. And then also when they're intoxicated on the substance, it can change how they present. And so that's another important piece that kind of manifests, is this really rapid and noticeable change in the way somebody's acting. So I know that was some background, some in-depth background about addiction. So if there are questions that you have about that process, please feel free to put them in the chat and I can happily answer them at the end. So now I'm going to move on and talk a little bit about substance use, specifically in older adults. So, why is this an important and relevant topic? So I think we've all heard of the silver tsunami, which basically means that the number of individuals in the US population over the age of 65 is dramatically increasing. And the reason for that is twofold. First, it's because baby boomers are getting older, and also there's an increase in longevity. And so what you can see from this chart is that by the year 2050, it's estimated that over 20% of the US population is going to be over the age of 65. So we have a larger population of older individuals. At the same time, the incidence of substance use is increasing, especially in older populations. And so this is a graph from a national survey that looked at the number of individuals who reported illicit substance use over the past month. And you can see that the yellow bar at the bottom is ages 60 to 64. And so over the years, the number of people in that cohort saying that endorsing that they used illicit drugs over the past month has slowly increased. And we're seeing similar trends with alcohol and also the rate of prescription medication misuse. So it's creating an issue where we're having a larger number of older adults and also a larger number of older adults who are using a variety of substances. Even though this is becoming an increasingly prevalent issue, it's incredibly under-recognized in especially medical treatment. And there are a number of reasons for that. I think one of the most common is that oftentimes symptoms of intoxication or withdrawal are much harder to recognize in older adults compared to younger people. A lot of times, older adults also have a number of physical or medical issues. And so withdrawal or intoxication might mask as other potential medical problems that could be going on. And so those are then treated instead of the substance use. There's also a stereotype that I think we all have about what addiction looks like. And we commonly think of younger patients, maybe with unstable housing, economic difficulties, that are really driven by substance use. And that's quite different from dependency in older adults, where their social situations are usually much more stable. They're probably drinking at home, or drinking or using substances at home alone, and there's not as much of an economic impact because they're retired and more financially stable. Because of the under-recognition of substance use disorders in older adults, they're also less likely to be referred for treatment. And there also are less treatment options for older adults. So the increasing number of older adults with substance dependence, at the same time with the under-recognition and under-treatment, is creating what some people call a silent epidemic of older adults using substances and not getting screened or referred to treatment. Like I mentioned before, there are different symptoms that indicate substance dependency in older adults compared to younger individuals. So, some of the common things to look or screen for are psychiatric difficulties, and these can be seen certainly in younger patients as well, but that there's sudden onset irritability or depression or mood swings. Much more commonly, there can be physical symptoms, and this oftentimes goes along with the intoxication or withdrawal phase, such as nausea or vomiting, tremors. Another really important warning sign in older adults is unexplained falls or bruises that don't necessarily, there's no known injury. And also decreased ability to care for self or malnutrition because they're using substances, and that's causing subsequent self-neglect. Another big symptom is confusion or disorientation. And of course, in older adults, this can be caused by a number of different things. But if there's a very acute change in short-term memory or reaction time, that may indicate that there's substance issues going on. Social and behavioral changes are also quite common. So withdrawal from family, more discord between family members. Other indications to watch out for also are needing to refill prescription medications earlier, going to several doctors or several pharmacies to fill prescriptions. So these are all signs of a possible substance use disorder that should be looked for in older adults. There's also a very significant impact of substance dependency. And this is just one study that was done in 2011, looking at the average number of visits to just one emergency room for a patient 65 and older related to misuse of prescription medications or also illicit substance use. And on an average day, there were 118 visits for physical or medical problems related to pain relievers. And then you could see also specifically for narcotics, there were 80. So the number of emergency visits and also medical issues that are arising from these medications is staggering. So if you think of this is just one emergency room, all of the emergency rooms across the US, I think this really gives a sense of how significant the impact of substance use is on older adults and their physical health. I'll now talk a little bit, give some of the specific details of certain substances. And I'll start with alcohol because, like I mentioned, this is the most commonly misused substance in individuals over the age of 65. So the prevalence these are some statistics that were obtained from the 2018 National Survey on Substance Use and Health, and I think they're pretty significant. So 1 in 10 seniors report binge drinking over the course of a month, and binge drinking is defined as 4 to 5 drinks in 2 hours. 1 in 40 seniors report heavy drinking, which is, binge drinking several days over the course of the past month. And then also 1.6% of seniors have been diagnosed with alcohol dependency. So this is quite a significant portion of the population that's either engaging in heavy drinking or even having dependency problems. And binge drinking or heavy drinking is especially causes increased risk in older adults because older adults also metabolize alcohol differently than younger adults. So when an older adult has, let's say, 1 drink of alcohol, the effects are felt faster, and they're also felt for longer because alcohol is not metabolized at the same rate once you get older. There are also more risks in older adults for having side effects and problems as a result of intoxication. There are a number of medical problems that are exacerbated by alcohol use. I think, we all commonly think about diabetes, osteoporosis, liver issues. Any amount of alcohol can worsen those underlying medical issues. The other problem too is that alcohol interacts with prescription medications and can increase their effect, including things like antidepressants. And so older adults can experience worsening confusion, more severe intoxication, because they're also having side effects or problems because the alcohol is changing the way that their prescription medications work. And since older adults are oftentimes on many more medications than younger adults, this is another really important consideration when seniors drink alcohol. Because of this, the National Institute of Alcohol Abuse and Alcoholism has different guidelines for how much alcohol individuals over the age of 65 should consume. And so the recommendation for men is that they should have no more than 1 standard drink per day, which is, a can of beer, 1 glass of wine, and at a maximum, they should have 2 drinks on any occasion. And the recommendations for women are even lower than for men. And so you can see where it can be problematic, especially if seniors are having multiple drinks on occasion, binge drinking, or engaging in heavy drinking, because the recommendations for them are much lower than younger adults. One of the other important things that I want to bring up that I think is often not discussed is that alcohol can have significant effects on memory. In older adults with underlying memory difficulties, the short-term memory can be further exacerbated by alcohol use, and long-term alcohol use can also predispose individuals to dementia. And so this is an interesting study that basically shows brain volume depending on how much somebody has drank over the course of their lifetime. So the picture on the left is looking at the brain volume of a 57-year-old man. The picture on the left is the brain of somebody with alcohol dependence. And so you can see that there's much less volume, there's more open spaces compared to the picture on the right, which is a control subject who drank the recommended amount of alcohol. And so with time, alcohol is a neurotoxin. And so alcohol in and of itself can lead to permanent brain changes and memory loss. So I'll now move on and talk a little bit about prescription medications. First, I'll discuss opiates. And I think the opiate epidemic in our country is, of course, widely talked about, very much in the public eye. But again, I think that there's a bias towards thinking that the opiate epidemic is something mostly for people in their 20s and 30s. However, it is especially an epidemic in older adults as well, because they have more difficulties with pain, more procedures, and so they're much more likely to be prescribed opiates compared to younger adults. So in younger adults, it's more issues related to heroin use, and with older adults, it's oftentimes misuse of prescription pain medications. And so at first, oftentimes these medications are prescribed for a very legitimate reason, whether it be post-operative pain or acute back pain, but with continued use, that can lead to overuse and dependency problems. And I was talking earlier about how substances that can lead to dependency affects the rewards pathway in the brain. And that's basically exactly what opiates do. So the image on the right, the image on the page, the image on the left shows what the normal brain looks like, because we all produce some level of endorphins. Let's say you go for a run. And so these are kind of some of the brain, similar to dopamine, like some of the brain's kind of like natural feel-good chemicals. And endorphins bind to the opiate receptors and then cause dopamine release. Opiates work in the same exact way as our natural endorphin system. Again, they just kind of hijack it and activate it to a much higher degree. So there's that same similar dopamine release and subsequent euphoric feeling. And that's with time what can create the issues with dependence and addiction with opiate pain medications. And for those of you not as familiar with opiate pain medications, a couple of the common names or the common medications that are prescribed are Norco, Vicodin, and Percocet. Similar to alcohol, opiates have more side effects in older adults. Some things that we worry about in particular is that opiates cause respiratory distress, and they decrease the respiratory drive. So especially patients who have any kind of underlying breathing difficulties, whether that be COPD, asthma, taking these medications increases the likelihood that they might experience respiratory distress. There are also problems with short-term memory difficulties and falls because opiates impair reaction time. They can also cause stomach upset, severe constipation, and because older adults don't break opiates down as fast as younger adults, similar to alcohol, the effects happen quicker and last longer. Because of that, they're much more at risk of overdosing. And so taking more or taking an amount that is life-threatening or can cause serious medical complications. Also similar to alcohol, there's an increased risk of interaction with other medications that older adults take, or even more concerning, if someone is taking opiates and then drinks, the potential for respiratory depression, confusion, overdose are all that much higher. Even though we know that older adults are more at risk and there are the potential for significant consequences, the rates of opiate prescribing in older adults, as well as the rates of misuse, are actually on the rise. And so this diagram right here, so the the bottom line in green is individuals 50 years and above. And compared to younger age demographics, where I think there's a lot of awareness about the risks of prescribing opiates, and so there's, with time, less opiate misuse, in 50 and plus, the rates of misuse of prescription pain medications is actually on the rise. And so, oops, didn't mean to change the page, sorry about that. And so that's something just, I think, to really be aware of, is that more and more older adults are misusing these medications, and as a result, there are more medical complications that we're seeing from opiate misuse. I'll now move on and talk a little bit about benzodiazepines. And so these are considered sedative medications that are prescribed for anxiety or insomnia. And interestingly, benzodiazepines, they actually work on the same receptors in the brain as alcohol. So there can be a very fast-acting, immediate anxiolytic effect, meaning they decrease anxiety. And so they can, in certain circumstances, be helpful short-term. But when there's continued use or overuse, that's oftentimes where we see problematic issues arise. So examples of commonly prescribed medications are Xanax, Klonopin, and Ativan. There are a number of others. I would say that those are just the most commonly used out of the benzodiazepines. There are significant risks with benzodiazepines, and of course, similar to all the other substances I discussed, because older adults metabolize them far slower, the effects of benzodiazepines are more intense and last longer. So a couple of the risks I'll highlight. There can be a change in cognition on these medicines, so poor attention or concentration, drowsiness where people are falling asleep during the day. And interestingly, there are actually studies that show patients on benzodiazepines for years or decades also are more at risk of having dementia and age-related cognitive decline. And some of the thought about that is that these medications, similar to what I discussed with alcohol and the effects alcohol has on the brain, with prolonged use, benzodiazepines can actually be neurotoxic and cause volume loss and then subsequent memory difficulties as people age. There are also motor issues that are seen. So benzodiazepines put older adults at risk of falls, dizziness, injuries, and also that's because they can cause neurologic side effects, tremors, unsteady gait. There can be like severe periods of worse confusion after even just one dose. And also, even though benzodiazepines are commonly used to treat conditions like anxiety, once they wear off, there can also be rebound anxiety or worsening insomnia. And so they can, especially in the withdrawal period, have a paradoxical effect where they're actually worsening individuals' psychological state and mood. Similar to opiates, even though there are well-documented risks of benzodiazepine use in older adults, the incidence of prescribing is increasing. And interestingly, especially in women, and that's likely related to the increased incidence of depression and anxiety diagnoses in women compared to men. And so, you can see even, patients in their 70s and 80s, 10% of female patients in that age range are being prescribed a benzodiazepine and about 4% in men. And so that's a pretty staggering number, especially if we think about the ever increasing population of people in that age demographic. And then, similar to other substances I discussed, the risks using benzodiazepines in conjunction with potentially alcohol, opiates, or illicit drugs, as well as prescribed drugs. That there's, just a higher rate of potential complication and medical issues that could result. One other thing I want to talk about too is that opiates and benzodiazepines with long-term use can have a really significant impact on mood. And this is a diagram taken from a 2018 study that looked at the risk of suicidal thoughts over the past year, depending on whether an individual also endorsed misuse of opiates or benzodiazepines. And so you can see that if an older individual is misusing opiates or benzodiazepines, the risk of them having suicidal thoughts is about 4-fold higher. If you take misuse of both medications in conjunction, it's even higher. 25% of those individuals report having suicidal thoughts over the past year. So I think that really demonstrates that while these medications have significant physical and medical impact, there's also a dramatic effect on mood and thinking. So now that I've gone over the most commonly used substances in older adults, and just to get a sense of, and kind of gave a sense of how significant this epidemic is, and also what the risks are with untreated dependence, the next question is, how do we address it? And so I think the first thing is, anybody working with older adults in the community, or even us in the medical community, need to kind of be vigilant and be on alert, looking for some of those common signs that might indicate that there's dependency that I went over earlier in the talk. There are also really quick screening tools. I put one in the handout, which is the CAGE questionnaire. And so that has been very validated to screen for alcohol dependence. So if individuals answer yes to the 4 questions, that is very indicative that there's likely some kind of alcohol dependency problems. And so that's actually a scale that's commonly used in clinics like my own. And it just takes a couple of minutes to go through. So I think that's always kind of a nice resource to have. If you're seeing the warning signs, that can be kind of a further tool to assess whether there are alcohol dependency issues. I think another important thing is to destigmatize substance dependence. First, that it is a prevalent issue that older adults struggle with, and also to understand, just like diabetes or high blood pressure, that it is a medical illness that can be treated. And so if there's any concern, of course, encouraging someone to have a discussion with a health professional who is trained to diagnose, to first screen and also diagnose substance dependence issue, just like an older adult would with any other kind of medical concern. I also want to emphasize that there is help, even though oftentimes there are less treatment options for older adults. There are a number, and here in Denver, actually, there are quite a few outpatient, ranging from outpatient to intensive outpatient, where somebody would go for a couple of hours for 2 to 3 weeks, to residential, where somebody stays somewhere for a month to 2 months, where they can get expert help in terms of managing any medical issues that are arising from the dependency, as well as long-term psychological help to manage cravings. And the other thing I want to bring up too is that, beyond, I think that there's a lot of perception that most of the treatment for substance dependence is like talk therapy or group therapy. And while that is an important piece in terms of like learning the coping skills to manage cravings and prolonged withdrawal symptoms, there are actually FDA-approved medications that can be used to help mitigate the symptoms of dependency even in alcohol use disorders. So there's a lot of different modalities that can be used to help with substance dependence. The other thing I wanted to mention too is that in the handout I gave you guys, there's also one from SAMHSA, which I can't remember exactly off the top of my head what it stands for, but it's an awesome resource. It's a website pretty much entirely dedicated to substance use disorders. And on there, they have resources for a phone number so you can call in terms of treatment resources. They also have wonderful guides, just one I printed out that talks about how do you have these conversations around substance dependence, because it often can be very difficult and challenging and very emotionally charged. So they have a wealth of articles, resources, and knowledge on that website that if you guys have any more interest or want to look more in depth, you can always look them up. All right, so that's my presentation. I'd love to answer any questions that came up.
We do actually, Dr. Drake, have a couple that have come in that are really good. So first, I'm glad you just mentioned your resource handouts. We did have a question early on about replicating those. Is it okay if they make copies for colleagues and peers?
Absolutely, yep.
Okay.
I think the one from SAMHSA says it's from SAMHSA, and you can also access it from their website. So I think that they are completely on board with disseminating that information.
Okay. Perfect. So there we go. So if you want to share the resources that Dr. Drake has provided, please do so. Here's a question around compulsive eating, eating disorders, or binge eating. Are those considered to be addictions?
That's a great question. So eating disorders and binge eating disorders are considered, they're in their own separate category when we think about like the DSM, which is kind of how psychiatrists diagnose certain psychiatric conditions. So those are actually, while I think certainly there is a component of like compulsive behavior that is treated in a different mechanism compared to substance addiction. I absolutely do think that there's a lot of talk and evidence that certain types of like eating and overeating, there can absolutely be an addictive component to that. There's certainly literature on sugar addiction, and there are, and some of the treatments that we use for management of substance use disorders can also be helpful when we think about addiction to eating. So I think that's an emerging field, but certainly that there's evidence for that.
Terrific, thank you. Here's another question from Rick. Is my family doctor aware of the differences in the medications related to my age, or am I likely being treated like a younger person would be treated?
Yeah, that's a great question. So, most primary care doctors, of course, treat patients of all ages. So I can imagine that they have understanding or expertise that there are certainly changes that happen when adults get older. If there's a lot of complexity or concern, there are also general medicine doctors that specialize in geriatrics, so geriatricians, where they primarily see patients over the age of 65 to help kind of manage all of their medical comorbidities. And similar to like me being a geriatric psychiatrist, they have added expertise in managing multiple medical comorbidities in the setting of memory difficulties. So I can imagine that the most primary care physicians would certainly take into account aging, the effect of certain medications on age. If there's ever a question or there's a lot of complicated medical needs, like I mentioned, there are also geriatric medicine doctors which is basically, that's their area of added specialty.
Terrific, thank you. And then Eric asks, he's a spouse of a patient that has advanced Alzheimer's and was prescribed Benzodiazepine to subdue disruptive behavior. His question is, how can a caregiver understand when benzo is appropriate? How do caregivers work with the doctor to know which medications are appropriate, especially for cognitively impaired patients?
Absolutely, for sure. That's a great question. And I do think a part of that too, of course, is a case-by-case basis, working with the specific medical provider. And I think having a frank discussion about, you know, what are we using this medication for? What are the side effects that I should be monitoring my loved one for? And what is the planned, is this going to be a long-term medication? Is this a short-term medicine? Like, what are we expecting to see? And if there are risks that come about, like having a specific plan in place to adjust medications. So I think a lot of that is a discussion with the person prescribing it about, you know, what are the risks and benefits to help make the most informed decision for your loved one about the medication.
Great, thank you. And then Pam asks, kind of pertaining to a couple of your last slides around treatment options. Any recommendations for alcohol treatment facilities that take Medicaid and or Medicare, specifically for a low-income senior? There's some issues that certainly she's encountering surrounding age, and then also the COVID restrictions, which adds a whole nother dynamic. So can you talk a little bit about, you know, just COVID and trying to get in to these treatment, get access to these treatment options?
Yeah, absolutely. I mean, I think that has, of course, added a whole layer of complexity around an already complex issue of referral, especially because more residential treatment facilities are taking less patients. There are more restrictions around access. And also at the same time, I think because of the social isolation with COVID, an increased risk of substance dependence. So I am somewhat new to the Colorado system. I do know that there are treatment facilities, but I'd be happy. I have a great social worker who I work with who kind of knows all the ins and outs of resources. So I can share those with Jody, and then she can disseminate them to the entire group because, of course, there's a lot of complexities around insurance, and I want to make sure that I give them the right and most accurate information.
And that's a very good point. Dr. Drake, can you talk a little bit about the new seniors clinic that you're involved in?
Absolutely. Yeah. So I came to University of Colorado about 4 months ago now from the University of Michigan. And as part of my clinical role, I have an outpatient geriatric psychiatry clinic. So it's 2 days a week. And so I'm seeing patients over the age of 65 with any psychiatric concerns, especially those with coexisting medical problems or cognitive disorders. So I'll also pass out, when I send the resources, I can also give my email address. So if there are people you think would benefit from my help, certainly please feel free, or you can have their primary care doctor reach out to me for a referral.
We are absolutely thrilled that Dr. Drake is here because not only to have her on campus, but just the service of the clinic, because certainly mental health, you know, the resources available are pretty thin. So to have someone that specializes in older adult mental health, we're thrilled that you're here. So thank you.
That's very kind
for joining us. Yes. So are there any other questions? Please put those quickly into the chat room. So we've got just a couple more minutes together, and now is your opportunity to ask Dr. Drake a burning question that you might have. So while we're waiting for folks to enter any more questions, just a reminder that we will now take a holiday break, and we will come back with our winter webinar series in emotional and mental health in older adults. That will kick off on January 14th. And as I mentioned before, the topic for that particular day is anxiety and grief. will be presented by Dr. Sherry Gibson. Many of you remember her presentation a couple weeks ago around compassion fatigue. So she will now change hats a little bit and address anxiety and grief. So we're getting a lot of kudos here, Dr. Drake, for your presentation.
Oh,
so,
thank you. Thank you guys for having me.
Yes, want to pass that on. And Dr. Drake, it sounds like, is going to send us some additional resources. So I'll make sure that we get those out to the attendees of today's webinar. So if that is it and there are no more questions, then on behalf of all of us at the CU Anschutz Medical Campus, please have a safe, happy, and healthy holiday season. It's going to be like no other, so it'll be a little different, but you staying healthy is certainly the most important. So with that, I would like to wish everyone a terrific Thursday afternoon. And if you are interested in getting added to our email list for the Multidisciplinary Center on Aging, just put your, or email me. I put it in the chat room. And I'll make sure that you get added. All right. So with that, we will see everyone on January 14th. Thanks, Dr. Drake.
Thank you.